My first question, I would like to start with you, Dr. Kirakli. What is the evidence? Can be the evidence that you showed initially in your talk be translated to practice? And because if you read the paper, you see that Michel Arnal showed it nicely that it can be applied up to 95 to 99% of the patient in the ICU. Do you have situations where you cannot use Intellimed?
I think, as we see in the evidence, the adjustment numbers can be implemented quickly to ICUs, but in some specific patient groups, for example, a COPD patient who develops ARDS. So the algorithm sometimes sees this patient as a restricted pathology and tries to lower the tidal volumes and increase the rate. So we have an increasing CO2 problem. So that's also very challenging for the clinicians. So in some specific patient groups, the automation cannot help us. These are problematic. But in most of the patients, for the COPD, ARDS, or normal ones, if there's no other pathology ongoing, then it can be implemented that way.
How much percent do you think are a problematic patient?
It's maybe 5% or 10%.
And your ICU, it's a medical ICU, it's surgical ICU, it's a mixed ICU?
Yeah.
What kind of patient you have?
We have mainly medical patients.
Mainly medical
Yes.
patients. Okay. Patrick?
Yeah, so we are using ASV Intellimed as a default mode. Like, we start with it in every case, and in some rare cases, like 1 in 10 or 2 in 10, we have to change in severe IBS, for instance, mostly in restrictive disorders. So for those guys who want to implement ASV Intellimed or ASV as such, it is certainly reasonable to choose cases carefully, in the sense of do your first experiences with normal lung patients. You don't buy a car and you go off-road like day one, right? So the first thing is you learn driving on a nice paved road, and then you extend your experiences. But basically the system is I think good for default mode, and then you have to do it individually, as I said before, the sepsis round.
Worse? According to your experience with...
As Dr. Kirakli said, the difficult patients in terms of the algorithm are the ones that have a heart problem and a C problem because time constant is small. You'd like to have these patients ventilated like ARDS patients, but there is no clue for the algorithm per se to know which ones they are. So we can of course default set that they are ARDS patients, but probably in certain cases you won't get it right in terms of COPD in these patients. The other patients in our ward are the ones with extracorporeal CO2 removal with an ECMO that the algorithm doesn't know that there is another machine changing O2 and changing CO2, so the algorithm per se cannot work in these conditions. As far as I know, there are no studies that look at whether extracorporeal machines can work simultaneously with the ASV. And then all the patients, of course, with the huge leakage, like the patients that had a lung volume reduction operation that didn't work as well as it should. These ones you cannot ventilate with these ones because they cannot handle the leakage, and also the ones that have a central problem with their breathing, say they have Jane Stokes, because the algorithm looks into the past, approximates the future, and that's how he adjusts. But if somebody has a Jane Stokes and breathing, he's out of range. The algorithm does the right thing, but always a few seconds delay. So it could work
Yes?
I can have a comment on patients on ECMO. So I think we have to be very careful when you are connecting the patient to the ECMO machine. The CO2 is washed out quickly, and the saturation goes up. The algorithm tries to decrease PEEP. So if you want PEEP not to decrease to some point, you have to set the minimum PEEP very carefully, so the algorithm doesn't collapse.
That means you use
Yeah.
because we by default do not use it. We always use it in this situation.
Yeah, we used it one patient and we solved the problem. So you have to set speed manually or you have to set a lower limit.
Okay. Then the next question that I have to you is, what was the biggest challenge when you introduced IntelliVent in the US? What were the biggest difficulties actually?
Not to get too over enthusiastic. I think this was the thing. There is, as was mentioned before, there is the experts or the people who are kind of initiating the whole thing. They basically want to have it yesterday rather than tomorrow, and the team has to follow, do the whole process, and you have to give time to the team and do it like in small steps. I think it was very impressive how you did it, like in the sense of when you changed the system, like from Evita to Hamilton. You start with the same modes people are familiar with, so the transition shock is not too but it was basically us being the challenge, not to be too enthusiastic.
Worse?
I think on one part it's that the ones that are the geeks on tech are the ones that always want to have it, just everything. But it's also the other ones that have the loss of work, because intellectually it's a kind of game changer. I mean, before that, all you did was what the machine does. So you changed it, the machine does it. You changed it again, the machine does it. So you adapted to the physiology of the body. Now you just set the parameters, the range where you'd like to have it, and then thereafter the algorithm works within it. So you have to learn as a user what is a clever range where I'd like to have the patient. For example, like Dr. Yakli said with the patient, so you set the peak manually, or you give a short range from 12 to 40 or something like that, that it doesn't work the whole range down the road. So you always have what you'd like to have, and say, concept of these things. So I think it's mainly our part intellectually to change that the algorithm, you have to understand the algorithm, and somehow you have to have the confidence that if you set the ranges right, it does the right thing. Besides the fact, of course, that there's certain things that the machine just cannot know, like sedation, analgesia, like a new problem, hemodynamic or whatever.
I believe a question for you. It is a problem, it is a challenge having different ventilators in the ICU. You mentioned, as I understood, you do not have all your patients having IntelliVent. Is this a challenge, or what are the problems there? Shall I buy one ventilator to see whether it works or not, or should I change all ventilators?
Actually, we don't have IntelliVent in all of our patients, but we have ASV and we have Galileos. So we are very experienced, and our team is experienced with ASV. So we didn't encounter so much problems when switching to IntelliVent in some patients. And as we were using ASV as a default mode, the most interesting thing for our team was the monitoring FiO2, not the SpO2. So, but now they're getting used to it. We're well. That was not a problem.
Okay. Time is running fast. thank you very much for coming here, for giving us your experience and sharing your experience with us. And I wish you a nice day here in Michael. Thank you very much. I do. Thank you very much.